Hi, I'm Dr. Angeline Yong, the Senior Consultant Dermatologist at Angeline Yong Dermatology. I'm a dermatology surgeon. More importantly, I'm a fellowship-trained Mohs Micrographic Surgeon, and I also do cutaneous reconstruction post-Mohs surgery. Now, because Mohs micrographic surgery is done under local anesthesia, the patients are awake throughout. Mohs micrographic surgery is a superior technique for treating certain types of skin cancers because of its tissue-sparing ability. You're able to tissue spare and keep margins as tight as possible. Secondly, it is more precise as well because you have same-day contemporaneous frozen section margin control. So you're able to ensure that the margins are completely clear before you attempt any closure. On the other hand, standard wide excision, you do not have actual real-time histologic tissue examination. Hence, there's oftentimes maybe a small risk that in more infiltrative or difficult tumors, you might not get complete margin clearance before you close. Lastly, Mohs micrographic surgery has superior clearance rates when compared to wide excision. So we're talking about 99% clearance rate for basal cell cancers and squamous cell cancers. With regards to skin cancer, I'm oftentimes faced with this question. Patients come in wanting to evaluate a lump that has been growing or has been changing in size. So the first thing I'll ask patients, if I don't get to see them in person, is really how long it has been changing. Is there any color change? What is the time frame that it's been evolving? Is there any symptoms? Is there any pain? Is there any itch? Is there any spontaneous bleeding without any trauma? These are all pertinent questions that we will ask before seeing the patient. So a lesion that is sore, that sort of keeps breaking down and doesn't heal over a period of time should warrant some attention. For example, you can have a little red bump on the face and think that it's an acne spot. It repeatedly doesn't go away. It's in the same spot after 2 or 3 months. I think it deserves a second look. So skin cancers, again, is a very broad basket term. Depending on the type of skin cancer, the prognosis really varies. So I would say that the most common skin cancers being basal cell cancers, squamous cell cancers, and melanomas. These three are very, very common. I would say that I would rank in terms of severity, basal cell to be the least, squamous cell between, and melanomas on its most severe form of skin cancer in terms of mortality risk. Basal cells are usually more locally destructive and invasive. They very, very rarely would spread to other organ systems, what we call metastasis. Squamous cells, there is a risk of metastatic spread. And then melanomas are the highest risk. So if we talk about is it life-threatening, then I would say that in that incremental order. Basal cells, I would say that the options can range from topical chemotherapy to using even cryosurgical options for very superficial types of basal cells that are quite small, to ranging to non-invasive treatments like radiotherapy if surgery is not an option, for example, in a much elderly patient or over certain surgical locations that might be difficult to primarily do reconstruction for. Surgical options tend to be the best with regards to the least risk of recurrence, so that sometimes is a preferred option if the patient is amenable to surgery, especially for the more invasive histological subtypes. And in terms of surgery, there will be mainly two main options: a wide local excision, which is standard treatment, and also Mohs micrographic surgery, which is better option for facial locations, for more cosmetically sensitive areas, and for higher risk subtypes. So that would be the main range of treatments available for basal cell cancers. Now, when it comes to squamous cell cancers, usually topical treatments are not so suitable unless it's a very, very superficial form of squamous cell cancer, what we call Bowen's disease or squamous cell carcinoma in situ. That's where the squamous cell carcinoma cells basically only invade the top layer of the skin. That sometimes we will utilize topical chemotherapy creams or a treatment known as photodynamic therapy to kill off the cancer cells. If it's not Bowen's but it's a more frankly invasive squamous cell cancer, then the options of radiotherapy and surgical treatment will be preferred. And then when it comes to melanoma treatment, usually the standard of care would be wide excision. again, the margins will be determined based on the depth of invasion of the melanoma. Based on the depth of invasion, the excision margins can range from 1 cm up to 2 cm, and then there might also be perioperative staging as well that may be required. So there might be further adjunctive treatments with immunotherapy and also with chemotherapy. So that would be the main treatment options for melanoma. So with Mohs Micrographic Surgery, it is a very precise technique where basically the tumor cells are really removed layer by layer with same-day visualization of the histologic specimen. So when a patient comes in, I always tell the patient, because results are done on the same day and is done stage by stage, to be prepared to be in for at least half a day to the full day. So what happens when they come in is that we will prepare the patient for surgery, we take preoperative photographs, and then we will confirm the area to be treated. We will mark out the lesion, compare it again with the pre-biopsy photographs, and then what we would do is to basically mark out the tumor to be debulked and take a very tight layer around it, usually about a 1 millimeter margin. So that will be the first stage, and that will go off to the frozen section lab, and it is done in my lab as well. And then we will process that with tissue dyes and with markings to allow us to precisely map back to the patient should there be any microscopic tumor found in certain areas of the layer that we've taken. When the results come back to me, or rather when the slides come back to me, I would then read them with my microscope, and then if I see no further tumor in that stage that we've taken, I would inform the patient that we can subsequently progress to close and reconstruct the defect that we've created. If I find still microscopic tumor in the corner of a section, I would inform the patient that the tumor is still present in one small area, and as I mentioned, it's Mohs Micrographic Surgery. So we're able, because we actually tissue mark and dye the specimen, and we mark it out as well very precisely on a map, we're able to go back into the patient and then very precisely take out a very small segment where the tumor may still be involved. So we don't have to sort of take unnecessary tissue. It is, as a result, a very tissue-sparing technique. We take only what is needed, guided microscopically. And then that extra specimen goes to the lab again. And then my histotech will process that. Slides come back to me, and then I read the second stage. If the second stage is not clear, we subsequently go on to the third stage. But if it's clear, we will then proceed to repair. Because we're doing very precise margin control here, so we really want to take our time and make sure that we clear out the tissue and every microscopic bit of that. This is also the reason why Mohs Micrographic Surgery is superior in terms of clearance rate compared to standard wide excision. So while standard wide excision typically gives 95 to 96% clearance rate, Mohs Micrographic Surgery can achieve 99% clearance rate, which means that the risk of recurrence in 5 years is less than 1%. So with Mohs Micrographic Surgery, it is a tissue-sparing technique, hence the reason why we select it in very sensitive areas around the nose, around the eye, where every millimeter counts. So first and foremost, when I take my Mohs stage, I would take as tight a margin as is physically possible, so that would actually mean that if the tumor clears out with such a small margin, the patient actually has as small a defect as possible for me to subsequently reconstruct. So on the face, it's absolutely important to try to reconstruct in anatomical subunits. What do I mean? If the tumor or the defect involves two subunits, like it spans the upper lip, and let's say it spills over into the mid-cheek, and it's a biggish defect, I would repair the two segments separately if possible, so that I do not blunt the anatomical margin. Segment repair is very important to achieve very natural results. So other than keeping to the anatomical subunits, it's also very important to try to repair along relaxed skin tension lines. So what do I mean? Now, if you look at somebody in the 20s, you might not see it very evidently. But you look at somebody in the 50s and 60s, you would see fine lines appearing on the face. So where do the fine lines happen? The fine lines happen in certain locations, in certain directions, based on our wrinkle lines. So when we smile, we get lines that go across this way, following our middle fold. So in knowing that is a natural pattern where relaxed skin tension lines form or wrinkles form, I would try, if possible, to push the repair, the suture line, into a relaxed skin tension line, so that over time, the scar fades into a natural crease. So that's another way to achieve superior cosmetic results as well. Now, when it comes to repairing, there are many options along what we call a reconstructive ladder. It can start with primary closure, which means a smallish defect can be zipped side to side in a straight line. So if that is feasible and I can hide it along a natural wrinkle, I would do that. Or if I can hide it along an anatomical subunit, a border of that, like a middle-labial fold, I would absolutely do that. If the defect is larger and cannot be primarily closed, then we have other options. So what do we have? We can subsequently repair with what we consider a flap repair, a local regional flap repair. So when we do that, in order to simplify that, what we want to do is achieve good tissue match and borrow skin from a neighboring reservoir to free that so that we do not actually have a pool that distorts a free margin. So bearing into mind on the face, there are what we call free margins, there are natural wrinkle lines, there are anatomical boundaries. We try to respect all that and try to reconstruct within those boundaries. And then finally, we can also do a graft repair. Graft repairs are quite simple. Basically, we take an extra piece of skin, maybe from the front or the back of the ear, and then we do a patch repair. And the last option, of course, to mention is what we call secondary intention wound healing, which means letting the wound heal on its own. So in Mohs surgery, I was able to scrape a very shallow defect, and it was in a suitable location, like maybe around the middle part of the eye, a concave area of the skin. This area, we can subsequently actually let the patient dress up and let it close up on its own. It heals very well by natural healing.